Hello, welcome. Before I turn things over for the main event, I wanted to make a quick announcement. I know that last week we said, or someone announced that Sarah Flood and the team that worked with her had successfully recompeted for the P30 Life Course Center grant. So, second, congratulations. Um, I wanted to stagger that announcement with another announcement, which is that we have also a collective of us, led by Gina Ramore and Kathy Fitch, who's here somewhere, and I as the leaders, but really it's a team effort. Have successfully stolen the coordinating center for all the P30 demography and economics of aging centers away from Michigan.
Wow.
So we are now, as of a week or so ago, the coordinating center for all of the demography of and economics of aging centers, which means that we will coordinate, organize all of the work of all of the centers and publicize all the work that they are doing and support their emerging scholars. So we are the leaders, but really this builds on many years of excellent organizing, coordinating work, helping emerging scholars, publicizing, getting the word out. It is a collective accomplishment. So, congratulations to all of you.
Yes, and I would acknowledge that this is a larger grant than a typical center grant would be. So congratulations to Rob, Gina, Kathy, and the entire uh, team for that U24. It's an amazing accomplishment. So now for some announcements here, I want to remind us about next week. Next week, we are really excited to have a practitioner coming. Mary Jo Webster is going to join us for our seminar. She's the data editor from the Minnesota Star Tribune, and she is going to present on how journalists use data to tell stories. And she uses our IPAMS data. So that should be really exciting. So please join us and ask some applied questions for our journalist. So that's pretty exciting. All right. So now this week, we are honored to have Susan Mason presenting for us. Dr. Susan Marshall Mason is an associate professor in the Division of Epidemiology and Community Health here at University of Minnesota. As a social epidemiologist, her research focuses on the population health impacts of adverse and traumatic experiences, including childhood abuse and neglect, sexual violence, racial segregation, and other forms of violence and social marginalization. The overarching goal of her work is to advance the evidence base for clinical practice and public health action to prevent these adversities and their negative health impacts. Now, Susan, I am proud to give you the coveted seminar mug,
Thank you.
which you can only receive by presenting at this wonderful seminar series. So we're honored to have you. Thank you so much for coming over to present.
Wonderful. Thank you so much. I'm delighted to be here. I'm a huge fan of the Minnesota Population Center. As a pre-doc, I was a fellow at the Carolina Population Center, and actually, my first sort of recognition of the MPC was when I was working on a project with Sherman James. We were trying to understand the impacts of um, desegregation on infant mortality. And I emailed the MPC to try to find some data. And to be honest, I don't remember who I emailed or what the outcome was, but I remember that MPC was the place to go to get data. And I remember the response was very, very quick and very informed. So y'all have been on my radar for many years. And I'm just, anyway, I'm not here that much, but you all are in my heart. um, Today, I think I was invited because I have a relatively new RO1. We're in year two, looking at child maltreatment as a function of social safety net policies. Um, I'm going to tell you up front, it's early days. We are still acquiring and cleaning data. I have no results to present to you. So I'm taking this opportunity instead to offer kind of a big picture conceptual talk and a slightly autobiographical talk to tell you sort of where I've come from and why I've ended up in this place to pursue this RO1 project. All right. So I'm going to start by I mean, hopefully, you all don't need a lot of convincing to see that child maltreatment might be a public health issue, but hopefully, I will convince you that it's maybe a bigger public health issue than you were perhaps aware. Um, and also, we'll emphasize how little attention it gets as a public health issue relative to other things that we treat as really important. And then I'm going to go into child maltreatment surveillance. We're going to have a little Epi 101 sidebar. I literally pulled a slide from Epi Methods 1, which I taught up until this past year to master's students, to tell you why the data on child maltreatment is such a major problem in terms of doing public health work, particularly prevention work in this area. And then I'm going to talk about two different areas that I've worked in to try to get a handle on like alternative data sources that can give us some traction on understanding the patterns of child maltreatment, and what could possibly be done to reduce the rates of child maltreatment. Before I get started, I want to acknowledge some outstanding collaborators on my current R01, who also many of them go back many years. Um, I have Berkeley colleagues Jen Ahern and Corinne Riddell, who've been working with me for a long time. Um, Krista Farkas is my postdoc, who used to be Jen's students. So we're just circulating around into different positions. Patty Schnitzer, I'll mention, she was at Missouri for a long time. She's an injury epidemiologist and has done a lot of work on child maltreatment using hospital data. And then when I talk about the social safety net information, that's the work of Tara Watson at Brookings and Lucy Schmidt at Smith. I also just want to acknowledge the National Institutes of Child Health and Development for funding this. And then in addition, the work that I'll describe during COVID using Google search data came from a Epidemiology and Community Health internal award, the Holly Award. Okay. And I'm happy to take questions throughout, although I'm told there's some issues with Zoom. So I will try to repeat your question if you ask um, during the talk. So the first thing I want to start with is just to emphasize how important child maltreatment is as a public health issue. And when I say maltreatment, I mean abuse and neglect. I think often just as sort of lay people going through our days, our awareness of child maltreatment really is in the form of very severe physical or sexual abuse that makes it into the news. A child dies, there's something really egregious that's happened. It's actually not the average at all. Um, the modal case is a case of neglect in an impoverished family, generally. Um, so, child maltreatment is highly prevalent, maybe more than you might expect, given, again, our sort of attention to these very rare and very egregious cases. And it's a plausible cause of poor social and health outcomes across the life course. And so I've repeated this sentence in multiple grants. Adults with maltreatment histories are twice as likely to be unemployed as their non maltreated counterparts, 3 times as likely to attempt suicide, 60% more likely to develop drug use disorders, 40% more likely to develop obesity, and 60% more likely to develop cardiovascular disease. Um, the causality of this can all be questioned, but there's very consistent and very widespread evidence that maltreatment may have these long-term life course outcomes, including things that we really do care a lot about as public health people, like cardiovascular disease, in addition to shorter term child mortality, child injury, and things like that. So when I say it's highly prevalent, I'm not kidding. Um, this is a really nice paper by Kim et al. They actually use life table methods to try to understand what is the lifetime prevalence of it for a child, like from birth to age 18, of being involved as a victim in a CPS, a Child Protective Services investigation. And they found it's actually 37%. And that goes up to 53% for African American children. So pretty big racial disproportionality. That's what they call it in the social work area, disproportionality. Um, Now, not all of these cases are confirmed. They did this again and looked at substantiation. It was about 12.5% of kids are involved in a substantiated case. So that might seem really high. I want to emphasize here, and I'll get this in a minute. This is all based on Child Protective Services. This is by far, like very, very far from a perfect system. Um, it's catching kids who probably shouldn't be in that system, or probably missing kids who should be. Um, it's frankly a mess. And so I just want you to put kind of a caveat on this, that these numbers are not necessarily telling you that 1 in 3 kids have experienced abuse. However, other data sources do suggest kind of similar numbers. Um, the Adverse Childhood Experiences Study, which asks adults retrospectively, finds about 1 in 3 people report having experienced specific instances of abuse and neglect. Um, David Finkelhor over in New Hampshire has done this national survey of crimes against children where they actually survey parents and children and ask them about this stuff. And they also find the 1 in 3. Now, the numbers are sort of consistent. At the same time, you don't necessarily find that the people who have report ACEs retrospectively are the same people. So it's not clear it's the same 1 in 3. But I think there's plenty of evidence this is not sort of like a highly, extremely rare event. Okay. So this is the autobiographical part. So I kind of came into this world looking at the downstream consequences of abuse and neglect, or at least the downstream sequelae associations of abuse and neglect. And that was where a lot of public health and epidemiology energy was for a really long time. And I think kind of is still there. So the idea was, and this all grew out of the Adverse Childhood Experiences study, where they asked patients in Kaiser Permanente retrospectively about their experiences of abuse, neglect, and also other forms of household dysfunction, like parents having alcohol use disorder, things like that, or being incarcerated, and then looked at their medical records, their charts to see whether they had a different rate of various types of outcomes, and found that they indeed did have much higher risks of a lot of different outcomes of, really, of great public health significance. So that sort of ignited this whole realm of people tracking various things. And so like I was involved in looking at cardiovascular events, gestational diabetes, weight status. And a lot of this was about kind of tracking back, like what is the mechanism here? If we think this is causal, what would the interventions be? Um, and I frankly got kind of tired of that work because I kind of felt like it was coming in way too late. Like, why are we were sort of accepting that these terrible things were happening, and then we're like, how are we going to fix these people once they're adults? And that just felt very at odds with like public health and social epidemiology from my perspective. So that was where I came from, but also the spark that made me like, we got to think about this as like more primary prevention. But hopefully you can see that, if these are the kinds of outcomes that we're seeing in people who've experienced in childhood, that um, we would hope it would get some public health response. At the very least, we know that there are immediate uh, consequences for children. In terms of causality, there's very strong evidence in terms of mental health outcomes. I think that it's more tenuous in terms of the physical outcomes, but nonetheless, there's a lot here that suggests that this should be really, really important to us. And yet, there really there's very little public health attention to it. Um, and most of the attention has really been kind of absorbed by this enormous system, this child protective services system. And in fact, it's interesting talking to people in epidemiology or public health who work in this field. I think this is maybe declining a little bit, but there was a lot of kind of territoriality around this issue, with I think social work really feeling like it was their issue. And when you have money at play, there's lots of reasons for people to compete. So anyway, like what are we doing about child maltreatment? Well, the big thing we're doing and that we've been doing for several decades is child protective services. Child protective services basically operates by getting alerts of a suspected case of abuse or neglect from a reporter, often a mandated reporter. So all states have certain professions they are required to mandated to report suspected abuse or neglect. They screen that in or screen it out, depending on the details of the case, and then they can decide to investigate and they can intervene. With the extreme being pulling a kid out of that home, putting them into foster care. In federal year, or in yes, in 2020, so a few years ago, but I don't think it's changed that much. $31.4 billion were spent on child welfare activities, with the vast majority on reaction. Now, child welfare people will say they do some prevention, but the system is not really set up for that. In adulthood, there was a big push to screen for these adverse childhood experiences, or ACEs. I think this was very misguided in a lot of ways, because no one knew what to do once you get the information, which totally violates the basics of screening. Um, I also don't think that probably ACEs are predictive enough at the individual level to make it actually that informative. I actually gave a talk, or I don't know, years ago, early when I was here, and someone from Ramsey County Public Health who worked in like diabetes came up to me and she's like, "I need you to tell me what to do. We are being like told that we have to screen for ACEs, but I don't know what to do when someone tells me of this information." I was like, "This is crazy." Um, so anyway, but I mean, I think in theory, if it were predictive enough at the individual level, you would screen and then maybe you would have some sort of intervention that was targeted to people who had particular sequelae, in the hopes that you would prevent these long-term outcomes. Oh, adverse childhood experience. Yeah, so I mean, really a lot on reaction, very little on prevention. There are some, like the CDC for a little while had a parent education program called the Triple P program. And my colleague Patty Schnitzer said, and they were like, and then they didn't want to fund any more child maltreatment research. They're like, we solved it. We have this parent education program. But like, I was like, who takes this class? I don't know. So it's like hard to see how that's really scalable and if that is actually addressing the issue. Okay, so who's read Jeffrey Rose's Strategy of Preventive Medicine? Okay, nice. If you have not, I highly recommend it. So this is adapted from that book. Um, and you all should appreciate this. You all understand the basic concept because you're population scientists. But the idea here is that there are kind of two main ways of addressing a public health problem. One is the targeted high risk strategy, and the other is the population strategy. So let me just tell you what these graphs say. So this is the population density, the probability of a given risk factor across the bottom here. So the classic example is like high blood pressure. So people are sort of, um, there's different probabilities, different high blood pressures. And then this dotted line is basically the risk intensity, like how much risk comes along with that particular risk factor. So if you're in this high tail, like high blood pressure, your risk of cardiovascular disease is quite high. And so the targeted high risk strategy is the idea that you decide on some sort of cutoff, you take those high risk people and you intervene intensively on that. So that's kind of our medical approach, is that we screen people for high blood pressure and then we medicate them and we put them on sort of intensive behavioral kind of change interventions and things like that. And I would argue that's sort of our current method with child protection, is that we get alerts that something might not be okay with a family and we kind of, dig in and really intervene intensively. I would say there's not a great deal of evidence that the intervention we do is effective, but it's the same general idea. And you can reduce the risk if it's effective. I'm not saying child protective services is, but blood pressure medication seems to be effective. You can reduce the risk in that high risk tail. Um, the problem, though, is that at a population level, the middle of this curve is much more numerous. Like there's just more people. So in terms of cases of the outcome, this produces a lot more cases than this tail. So even though these people are at high risk, there's just fewer of them. And so the population shift strategy, the idea there is to actually, if you could just shift the whole population, just take everyone down in terms of their risk, you'll have a bigger impact because you're actually moving the entire, much bigger swath of the population. Side note, this has been critiqued in for a variety of reasons, because there's situations where it doesn't work that well. But I think it's a really nice framework still for thinking about population prevention and the benefits of it. And certainly these things aren't mutually exclusive. You can do both. But this is my my primer on the population shift and why I think it's potentially something we should be considering with child maltreatment. Okay. So, in order to do this kind of work, to actually know what the risk is and where and what might work to actually shift the distribution, you need data. And the way we get data is surveillance. So, let me tell you a little bit about child maltreatment surveillance, such as it is. So, let me start. These are my Epi 101 slides. There's 2 slides on Epi 101. So, what is the purpose of surveillance, collecting data on health issues or exposures? Well, you just want to know what's happening. Like, is the risk going up? Is it going down? You want to develop hypotheses by understanding the pattern. Like, where is it high? Where is it low? And then you want to be able to direct prevention efforts where the risk is high and also evaluate that. Are you having an impact? So, all very good things. In order to do that well, you need to be able to compare frequencies across person, place, and time. I need to know whether the risk of my whatever I'm interested in is going up or down. I need to know where it's high and where it's low. And I need to know something about, is it, older people, younger people, higher SES, lower SES, etc. Okay, so that's surveillance. That's what we want out of a surveillance system. So let's talk about child maltreatment surveillance. So the main data source we have for surveillance of child maltreatment is the National Child Abuse and Neglect Data System. I'm going to call it NCANS. And this is actually kind of an amazing data set. I believe it is. I think there's like congressional legislation behind it. They were like, we got to collect this data. So it's basically Child Protective Services data from all states. That includes the abuse and neglect reports that are screened in, as well as any reports that end up with investigations and substantiations, and includes key demographics, the allegation, and then the sort of course what happened with that case. So it's a massive data set. It is population representative. It collects. It's a census of all the CPS screened in CPS reports. Two others that I won't talk about beyond this, but I will just note that they exist. The National Incidence Studies has had 4 waves since 1979. So that alone kind of makes you realize it's not super great for surveillance. You can't get very timely information. And basically, it's like what's in NCANS, and they go around and ask people, were there cases that you thought were abuse or neglect that didn't get reported, or like that got screened out that you really think were abuse and neglect? So it's a little bit of honestly a little strange, I think. And then again, David Finkelhor ran this national survey of crimes against children, where they literally, I honestly don't understand how this works with IRB or logistics or anything, but they literally random digit dialed families and asked caregivers and children about a variety of victimization experiences, including abuse and neglect. And I don't know how that happens. I don't know how honest anyone is, because presumably they would have to report. So I didn't. Anyway, I mean, it's kind of an amazing thing that they did, but I don't quite understand it. Anyway, and there's 3 waves between 1997 and 2014. So again, not great for timely information. So sort of what we're left with is NCANS. So what's the problem with NCANS? So first, let me just say that it's all states in DC report these data to NCANS. There's decades of data available. So there's really a lot here. However, you can't use these data to compare across place. It's very difficult, or you have to be cautious comparing over time. And we're concerned about comparing across people because there's a lot of discussion of racial and class bias in the Child Protective Services system, both in terms of who gets reported and then what happens to that report once it's in the system. So just to give you a picture of this, now this is from 2018, but you can find it in any year. This is a heat map across the state, and this is the victimization rate per 1,000. Now, this is substantiated cases. These aren't reports. This is cases that actually went to it through, and the investigator said, yes, this is a case of abuse or neglect. And the first thing I just want you to know is that most people who studied like the geographic patterns of health, there are kind of geographic patterns that you typically see. There's like there's clusters in places, often in the deep south, where it's higher. This doesn't look like any of those. It looks very, very different. And then there's also just some puzzling things. Like in this map, Massachusetts, or in these data, Massachusetts has twice the maltreatment rate of Louisiana. South Carolina has 5 times the maltreatment rate of North Carolina. Things that just don't seem plausible. And the reason for this is that every state has its own threshold for what constitutes abuse and neglect. There's a federal minimum. The Fed set a minimum of what, but states can go above that. Each state has its own mandated reporting laws, and each state has its own system for operating CPS. So some it's at the state level. Minnesota has a county level system, and how some states require you to actually know which county you're in when you want to make a report and know the number and then call during business hours. Some states don't. So, I mean, this is really a much more of I think, a reflection of the system than any underlying rates of true abuse and neglect in the country. Okay, so that's by place. So again, you really can't. I don't think you can say anything about maltreatment rates by place from CPS data, or very little. Okay, over time. This is from a paper that my team and I published not too long ago, where we looked at Child Protective Services, or NCANS data, over time by state. And you can see a lot of them are flat, but there's some weird bumps. So this West Virginia here, it's sort of trucking along, and then all of a sudden we see this enormous increase. Well, it turns out West Virginia implemented a 24-hour statewide reporting hotline at that date. And then you see this increase. Before that, you had to know which county you were in. You had to know the number of this, like the child welfare in that county, and called 9 to 5, Monday through Friday. So here again, you see these like funny blips. It means a lot more about the system than it means about underlying child maltreatment. And then when we're talking about by person, I mean, there's just like ongoing fights about racial and class, what they call disproportionality. Is this reflecting true underlying differences by population, probably having to do with resources and things like that? Or is there bias? I think it's both. I think there's lots of reason to think that, I mean, what institution doesn't have some racial and class bias in it? Much less an institution that's highly informed by cultural values, like what a good parent looks like, and by caseworkers who are coming right out of a social work program, young. I mean, a lot of these are like 20-year-old young women, often white women, aren't parents themselves, and they're trying to judge what's going on in a family with very, very often very, very complicated situations. So where do we go? So here I am. I'd really like to get information to do kind of population level, like how do we know what the risk factors for child maltreatment are? How do we know what works to prevent it at like scale, at population scale? And here we have these data that make it really, really tough. Well, during COVID, things kind of converged in a way that gave me an opportunity to kind of try something new. So this is my team during COVID. We got a little pot of money to actually look at Google search data, use Google search data to look at child maltreatment. Now, there's a lot of caveats around these data, and I won't go too deep into it, but I'll just tell you a little bit about it. I will just say this was maybe the highlight, even though it was COVID, like the highlight of my academic career, because this is me, this is Corinne, this is Jen. We were all working together, meeting sort of weekly, and Jeannie was my graduate student. Krista N was Corinne's student, and Krista F was Jen's student. And these students got on like gangbusters, and they were like the engine. So we'd like show up to this meeting and they would present this amazing data, and they're still working together. They're actually like just got some funding to do another project. So Anyway, it was a very it's obviously a dark topic, but it was a um, really positive experience for me. Okay, so the motivation for this work was that we knew that COVID-19 increased risk factors for child maltreatment, like conditions that we know are associated with child maltreatment risk. So things like school and childcare closures, mass unemployment, precarious housing, interruptions in services to high risk kids, like kids with special needs. And then isolation from normal social support. So people were highly isolated in these, in their homes. Plus, just stress and mental health challenges that come with that kind of social isolation and uncertainty. So, there was sort of in the background, like, this seems bad. Like, probably we're going to see some risks that go up. At the same time, COVID-19 messed seriously with the CPS data because a lot of the reports that come through are coming from mandated reporters, most of them in schools or childcare or healthcare. And kids weren't in school. So there weren't eyes on these situations. And so we do, in fact, if you look at the CPS data, see this plummet in reports during this time. So we were kind of looking around and pondering things. And we decided to use Google Health Trends as an alternative to CPS data or maybe a complement. Just because, like, what else? It was a time that there was very little in the sort of traditional data that seemed like it was going to be that useful. Um, So we identified abuse and neglect terms that might be searched by a child. And this is where our graduate students were just awesome. They read a bunch of qualitative studies, they looked at validated um, child abuse scales and things like that to get the kind of language. And then they went and did incognito searches using those terms to verify they returned the expected websites. And then terms that did not behave as intended were removed. So, for example, there was a term that we tried, mom not home, like trying to get at neglect. And it turned up this like YouTube video that had like a song about what to do when mom's not home, like what kind of trouble you could get up to. So the next slide I'm going to show you, I just want to it's, we're starting to get into like, there's some of the terms are maybe a little bit upsetting. So just if anyone needs to take care of themselves and leave, that's totally fine. Um, so just to give you an example, we had a general strategy of naming the perpetrator and then the action and then me. So, and then we concatenated different perpetrators. So, mom hit me, or mother hit me, or stepmom hit me, etc. There were a lot of these, like, there were a lot of words that went into this. And we included search terms related to physical, sexual, and emotional abuse. We ended up not being able to capture neglect because, like the mom not home thing, we just couldn't find terms that would actually get us the where we just didn't think any of them were the right getting us where we wanted to be. Weren't specific enough. Um, so we queried all these search terms for each state week from January 1st, 2017 through January 1st, 2021. And there's lots of weirdnesses to this data. Like like there's a lot of like data suppression below some sort of unknown like threshold. And there's like you don't even really know the scale. It's all like relative to other searches, but like multiplied by an unknown constant. And then there's like sort of rumors about what the constant is. It's like, is that it's a very strange world to be in. I mean, it was really interesting. I learned a ton, but also like it's not the kind of data that you would most want if you were trying to get really reliable information. So we had a couple of research questions. The first was pretty narrow. Did shelter in place policies increase maltreatment related searches? And for this, we did kind of a difference event study where we were comparing states um, pre and post the imposition of shelter in place policy to states that did not have a shelter in place policy. And then the second question was a little bigger and less, I guess, rigorous in a sense. We basically looked at COVID-19, whether it was associated with excess maltreatment related searches, using kind of an interrupted time series where we were looking with kind of looked at this sort of, I don't know, fingerprint of the previous temporal pattern, and then looked at post COVID and looked at um, what the I don't even know what to call it. rates is not the right word, but the level of maltreatment related searches post COVID and whether that fell outside the prediction interval. Okay, so the first one, this was the shelter in place policies and child abuse search volume. We found pretty much nothing. Um, so you can see the pre-SIP period, SIP, cell shelter in place, and then the post-SIP is kind of like bouncing around a little bit, but really nothing that you would say is like clear evidence that anything was happening. But just to note that this was a very specific, this was really comparing states with the shelter in place policies at a certain time with those who didn't. And I think there's reasons to think lots of people changed their behavior even outside of shelter in place states, even in states without shelter in place policies. Um, and then we looked at excess Google searches. We actually included intimate partner violence in this one. This graph I'll show you is for the child abuse. And I'm not sure how well you can see it, but you can see here that this is basically the temporal pattern with prediction intervals going back to 2017. This is when our shelter in place policies went into effect. And this is, let's see, one time EIP, what is that? Emergency, I don't remember. There were big payments that went out, remember that? And then there was the pandemic unemployment benefit that also happened. So you can see they're all sort of sitting within the prediction interval. I mean, this is not the most, this is all kind of associational, but you can see this cluster of higher levels of searches post end of that unemployment benefit. So maybe a little bit of evidence that there's an uptick there at that point. Okay. What am I doing on time? All right. Yeah. Yes, there is some seasonality. I don't know if we know. I mean, it probably has to do, let's see, I kind of remember it kind of goes up in the summer. I mean, that could be kids being home more or just less childcare, more kind of juggling. I think you see it kind of tick up right at the end too. It could just, I think, family stress and probably togetherness. um, so yeah, I don't know that it's been fully explained, but yeah. Other questions? Oh, sorry. The question was about seasonality for Zoom people who can't hear you down. Okay. So the other area that I've been really interested in, so the Google search stuff was kind of interesting, but also didn't feel like it was going to go anywhere. Like, there's not really any way to like make that data more better. Like, as far as I can tell, it's like really hard to figure out what exactly it's telling you. It's kind of cool as like a first look or an exploratory thing. The other area that I've been really interested in is actually using child injury data. And this comes out of a paper that was published by my colleague Patty Schnitzer, who led a big CDC effort to complement Child Protective Services data with child injury data. And so they did a really big, it was in Missouri where they have just strangely, like just a lot of ED and hospital data all linked together. And so they brought in experts first just to basically say child abuse experts, child maltreatment experts to say, these are the kinds of injuries that I would expect that come out of different types of abuse and neglect. And then they actually pulled charts with those particular types of injuries and then did an independent like assessment of those. Like different people came in and said, like, what is the probability you think this is abuse and neglect related? So importantly, this is not like providers saying this child has experienced physical abuse and diagnosed that. It's a separate thing that potentially gets us a little bit away from the potential for ascertainment bias by things like race and class, because you remove that judgment or blame. So an example here is for suggestive of neglect, codes suggestive of neglect, and these all have age limits. So, for example, poisoning by drugs or medicinals in a child under 5, it's considered suggestive of neglect. Now, I'm gonna go ahead, Mateo. You mean can you identify the state? No, you can't identify individuals. I'll de-identify. Yeah. Well, it's limited data set. I think it goes down to the county. You can, the county of residence, or at least the county where it was reported. Um, I'm sure there's something identifiable. I mean, actually, MinLink here has the individual and has linked them to like education records. But I don't think a lot of states have that. Um, Anyway, so I'll just pause here and say, like, from a public health perspective, I think one of the things that frustrates me about conversations around child maltreatment is it has a very kind of punitive and blame oriented approach. So it's like these bad parents did this bad thing to this poor child. And like my perspective just generally is much more like maltreatment is a sign that this family lacks the supports and other resources that they need. Now, are there extremes where there are parents that really should not be parenting and not be caring for a child? Absolutely. But I think especially when we're talking about neglect, which is highly linked with poverty, we're talking about situations where there's just a lot of need. Um, so that's sort of my caveat to say, like, I'm not pointing at this and saying, like, these are the bad parents. Um, but anyway, poisoning by drugs or medicinals. I mean, the idea here is just like if you have kids under 5 in the house, you shouldn't have drugs and medicinals sitting out within where they can be ingesting them. Similar with drowning in a kid under 4. In theory, a kid should be supervised in the tub at a young age. Have I ever left any of my children under age 4 in a bathtub for a moment? Absolutely. So again, this is not about, whether parents are being good or bad, but about, flags that things aren't quite optimal in terms of child well-being. So let's see. So one of the things that we did as a team was actually just do a sort of descriptive comparison of trends in child protection reports. So this is NCAN's data. Um, Across person, place, and time, basically, and compared that with mortality, where the cause of death was one of these injury codes. So pure descriptives. And I'll just show you a few things. So you can see this is mortality on the left. This is reports on the right. And one thing I'll note is it was just too rare to divide it out by like type of maltreatment, whereas the CPS reports we could divide it by type of maltreatment. Um, and you can see that they're not aligning in terms of time. And then this map shows basically the concordance of maltreatment reports and the maltreatment related mortality. The way we did this is they're very different scales. Mortality is much more rare than the reports, but essentially we divided the states into tertiles on both. So basically, you're in the top, middle, or bottom tertile for mortality. Same with top, middle, and bottom tertile for reports. And basically, the concordant is where you're in the same tertile. You're high on both, you're low on both, you're in middle on both. And you can see like the mountain states are pretty concordant, but there's some interesting clustering here where like in New England, they're very high on reporting and very low on mortality. In the deep south, it's kind of the opposite. What does this mean? I don't know. Neither of these are perfect data sources. Maybe it means that all this reporting they're doing in New England is working. It's saving kids. It also could mean they're over-reporting a lot. They don't need to be reporting as much. Down here, it means maybe they just aren't engaging. There's not a really muscular system to think about child welfare. Um, okay. So I'm invited to talk about my current R01 and you're going to get like 3 slides on it. So the current R01 is basically looking at social safety net generosity as a lever for primary prevention. There have been some studies looking at this with child protection data, various subtypes of the social data or different particular programs. We propose to look at both CPS report rates and rates of child injuries based on these injury diagnosis codes for a couple of reasons. First, because we didn't really trust the CPS report rates. Like, for example, you could imagine a situation where Medicaid expansion, reduced family stress, increases the amount of resources available to that family and reduces maltreatment. You can also imagine more families taking their kids to doctors. Doctors are mandated reporters. So you could also imagine it's going up. So we wanted that kind of a complement of the injury data. And the other thing is that just as like as a public health person, like you'd also kind of want to see something in the I mean, you'd kind of expect that injuries would be an obvious outcome of maltreatment, and you would wanna know that whatever you're doing is actually reducing, the sort of worst outcomes of maltreatment in addition to reducing reports. So why the social safety net? Well, it's a very widespread and a lot of people benefit from it, 1 out of every 2 children. There's been some evidence. So this looked at state supplemental nutrition assistance program policies, finding that there was basically if the state income generosity policies, basically like the higher income you could be and still get it, um, was associated with reductions in reports accepted for CPS investigation. I don't really have time to go into depth, but the idea here is we're basically going to use that state level variation in a fixed effects model to try to look at how states that say increase their earned income tax credit, um, how that is related to changes in both reports and child maltreatment related injuries. And one thing that's kind of fun, is that the safety net measure is kind of a cool simulation that was developed by Tara Watson and Lucy Schmidt, which has a couple of really nice advantages. One is that it actually does a better job of like estimating at like this population level. Like we're like at the state level, but we're going to basically estimate the benefits that a family would be eligible for based on some key demographics, child age, race, and then in some data sources we have like payer and things like that, and this does a much better job of accurately estimating that. And then the other thing that it does is it actually takes into account the way these policies play with each other. So things like cash assistance counts against food assistance. So if you look at them in isolation, you're not realizing that like netting out, it's it looks different than if you just look at one. So that's the exposure. We are currently acquiring the very expensive state inpatient and state emergency department databases that we need to look at the injury data. We have the NCANS data, starting to clean it all up. So I have no results to share. Um, and this is just what it looks. These are the state level fluctuations and the safety net overall. And you can look at program specific too. All right. So results TBD. That's all I got. Yeah.
This is amazing, stuff you're doing. And I just realized how difficult it must be to study this because there's such a social stigma to uh, report. I mean, obviously mandated report, but I mean among the family. But I was going to say there's also another factor. Like I was physically abused as a little kid. I didn't even find out until I was middle aged because no one told me.
Uh huh.
So, and I don't know how common that is. No clue.
Like you didn't recognize it as abuse,
No,
or
I
you
didn't
did?
know.
Yeah.
And I was also saying that I grew up witnessing emotional abuse,
Yeah.
and my memory has wiped it all the way through teenagehood.
Yeah.
And the only way I found out was I asked my brother a couple of years ago. I said, I knew all my life that with my father, you could never be late to anything. And I had just asked him, what would have happened if I'd been late? My brother's looking at me like, well, her dad would have been just like going into total rage.
Yeah.
I don't remember anything.
Wow.
So I've wiped this all the way at least through teenagehood.
Wow.
And so if you had asked me up until a few years ago, I would have said no.
Yeah. I
So
think.
so there's just gonna be this strong bias. I mean, both like the parents aren't gonna want to report it because right of the bias. The kids don't necessarily know if they're too young. The physical abuse was a different person.
Yeah.
And I didn't even, as I said, I was too young. I was probably like 3 or 4.
Yeah.
I just don't remember. So
Yeah. And there was a nice study I think in Australia where they looked at sort of the validity of the retrospective reports, and it's hard to know what people are reporting retrospectively for those reasons.
Well, so I was going to say that this is I don't know, an indication you should do whatever call this population shift strategy, because you have all these people who either don't know they're been abused or whatever, who
Yeah.
have lived through this. But I mean, I guess what I'm saying is if you're only targeting the people you know about,
Yeah.
you're going to miss all the people who either don't know or whatever.
Yeah.
So,
Yeah. It's interesting. Yeah. And it's just really tough. There isn't, I mean, it's like studying anything that's illegal or stigmatized. It's very difficult to get data on it in real time. Yeah. Other questions? Oh,
Thank you. Um, Hi. So you mentioned a little bit about how screening for AIDS in healthcare is not very productive. For example, AIDS is not very predictive of health outcomes on an individual level. So I'm wondering if you can talk a little bit more about what has been done. Is there any other alternative approach we can do compared to that? Or is there any way we can actually improve the predictive model for AIDS screening? Like when we can still screen for AIDS, but make it more
yeah. I mean, I
productive.
guess I shouldn't paint with too broad a brush. I mean, I'm not sure it's always unproductive. I just don't think that, I mean, it's one of those things that, like, at a population level, it seems to be predictive of a number of different outcomes. But for any individual, particularly with something like heart disease, I mean, there's so much happening, so many reasons we're all probably going to get heart disease, and so the the input of the ACE score just isn't necessarily helping us. Now, that might be different if there was some different kind of mechanism involved that, like, maybe people with ACEs have, a different pathway to heart disease. And so it would help us tailor treatment. But I don't think we know that yet. I mean, there's a little bit out there. So, I mean, that's my skepticism about it, is that it just seems like it's asking people to reveal a lot of personal information. It's asking providers to ask things they're not comfortable with and don't really know what to do with. And again, like, if you look at what the WHO says about screening, you only screen if you can actually do something that will prevent harm with the information you get from screening. I'm not convinced that's true with the ACE scale and the ACE screening. Now, it might be different in, like, for different outcomes, like mental health outcomes or substance use or something like that, where it may be a stronger tie and maybe more predictive. Does that answer your question? I mean, I don't know. I'm just not sure how useful it is to be reacting that late in the game. I mean, I think it's great for people to get therapy, to get help, like whatever is happening. And if they're having, some kind of physical health outcome, definitely you want to, like, intervene and make sure they're getting medical care. Um, I just don't. I just don't know that that piece of information is actually helping us give people better care. I would be willing to be proven wrong. Yeah, I think Andy and then Liz.
Um, but this is really cool, and I think the injury data has the benefit of capturing both level and intensity in a way that
Mm. Mhm.
surveillance would almost it would be impossible to capture both of those things as well as the observable consequences.
Mhm.
But and not to undermine your R1, but if you had an unlimited budget, what what do you think surveillance should do in this space? Like what like it
That's a really good
like it could
question.
it not get any better than it is? And it's just something that needs to be measured through observable consequences.
Yeah, I don't know. I mean, I think that I think it's one of those things that, because it's stigmatized, because it's illegal, it's really hard to know how to capture the information. I mean, the thing that if I had an unlimited budget, I would make sure everyone has really good health care and then use not only hospital data, but like primary care data too. Because what we're really missing is lower grade. Like, we're getting inpatient and ED data, but anything that happens below that, we're not going to get. And, like, part of that's good because there's going to be a lot of ascertainment bias in that, right? People just aren't going to seek healthcare for minor injuries if they're trying to hide a behavior. And so that's where I think, like, the inpatient data, it's much harder to avoid care if you've got, like, a severely injured kid. So I don't think that's a very satisfying answer to your question. But yeah, I guess it would be make sure everyone's getting healthcare and then go to, I don't know.
Yeah, thank you for the presentation. This is really interesting. I knew some of this from having previous conversations with you, but yeah, it really is messy. So, a bunch of us in the room work with data from the demographic and health surveys and from UNICEF.
Mm,
And so UNICEF is a good example. It has data from really 90, 95 countries that has their household surveys, and they ask parents specifically about violent discipline.
mhm.
Actually, they ask about all kinds of discipline. So you would get like calling children names or
Yeah.
hitting them, uh, and then how they hit them and things like that. I guess my first question is that what we're talking about when we talk about child mistreatment?
A great,
We haven't
such
exactly
a
defined it,
good
whatever the
question.
Child Protective Services says it is. And then the
Yes.
second thing is, I mean, and let's say under a different administration, is it possible that we could do household surveys in the US on these kinds of things?
Yeah, and that's really what David Finkeldor did. He did ask, both the parents, have you done this? And the children, have you experienced this? So let me answer that latter question first. I know the Future of Family Studies also asks about spanking, and there are people who use that as kind of like a proxy that if you're willing to like discipline your child with spanking, that's kind of like maybe a proxy for more harsh discipline. Um, so I would say, I think with probably sexual abuse aside, and we're not dealing with that here. We're really focusing on physical and abuse and neglect. I didn't say that here, but the RO1 focuses on that because we think that's probably more sensitive to these social safety net policies, and it's in young children. Um, I think, and with very egregious cases aside, there is a lot of subjectivity and really sort of cultural cultural framing around what constitutes physical abuse and what constitutes neglect. I mean, I would think that like the things that our grandparents did raising children would constitute neglect in the law now. I mean, in terms of just like leaving a kid outside or and it's also very class. It's different by class too in terms of um what is considered acceptable or appropriate. Um, so I think that Child Protective Services, they really looking at harm, and I apologize I didn't give this framework earlier, but they're really looking at like, is this kid at risk of being like seriously injured? Do they always hold to that? I'm not totally sure because you'll hear stories of cases where it's like not that clear that there's an immediate harm to that kid, but they're still reacting as though that is. So at least right now, I think in most, if not all states, like spanking would not, like typical discipline would not. Now I think Sweden has outlawed it, so that then becomes, the threshold can change. So anyway, yeah, it's very fuzzy, and the neglect I think is a mess because like one of the definitions of neglect is you're not giving the kid like basic needs, so you're not feeding your kid. Well, sometimes you don't have food or so for these caseworkers trying to parse that out, it's really challenging. And again, each state has a different threshold. Yeah.
I was wondering if there were enough locations with, for example, public school entry screeners to use that for trends. So, like, what they ask you in NPS are lots of behavioral and sort of emotional health questions about your 3 or 4 year old.
Huh.
And it would maybe not be great for levels, but that's going to be more or less universal for people entering public school systems. And
Interesting.
maybe
What do they ask that you think?
does your child like not speak? Does your child like
Oh,
use the toilet properly? Are they fearful of strangers? I mean, there's like,
so you're thinking of like developmental delays or something that might be a sort of
yeah,
signal of something.
yeah. So it won't be the injuries. The
Yep.
levels will be hard to infer,
Right.
but like the trends might be the right way.
Yeah. Yeah, that's interesting. That's a great idea. All right.
All right. Well, thank you.